Thank you very much. Thanks for Cancer Australia for sponsoring my talk. I would like to acknowledge the traditional owners of the land and also pay my respect to the elders, past and present. As most of you have heard, the Alan Walker Cancer Centre just opened in 2010. And before that, where do all the cancer patients go? Well, they went to South Australia, Melbourne, Perth, New South Wales, and just building the cancer centre there alone make a difference. And I'm going to show you some of the numbers that makes a difference. And because we are starting behind the 8 ball, Victoria, Sydney, Queensland all have cancer services beginning of time, and they are 50 years ahead of us. So when we first started, I came from Royal Adelaide Hospital, and we actually knew a lot of the issues, but we were only scratching the surface on Aboriginal cancer. When we came to Northern Territory, we realized that it is a whole a whole spectrum of things that we really open our eyes of what true Aboriginal culture is. And bearing in mind the Northern Territory, the Northern Territory Aboriginal people has got a lower health literacy. And if you have a look at the population in the Northern Territory, 1/3 of the people are Indigenous. When I was in Royal Adelaide Hospital, if I see one patient Aboriginal out of 100, that's what I see. But when I come to Northern Territory, 1 out of 4 patients in the cancer centre is Aboriginal. So the cancer centre has to be culturally appropriate from day one. And the population, you note, is 1/3, but we only see 1/4. There's a gap. We know there's a gap. There are many factors regarding that gap, so I'm not going to go into that. But there are 200 dialects in the Northern Territory. And you look at the spread of all the people. The most important thing you need to know is that 80% of all Indigenous Territorians live in the regional and remote areas, not in Darwin. Okay, they live regional. So we are talking about literacy levels, health literacy levels that are different. So what happened is from day one when we started, we decided to collect information that are useful to us, that will define our policies, our practices, and how we deal with Aboriginal cancer people. Bearing in mind, NTRO, we are actually a private organization. We are not a government body. We don't get any funding for all this research or anything that we do. It's just the passion of the staff and the clinicians in trying to make a difference to Indigenous cancer. So what we found out by the 2nd and 3rd year, we found that, as you know that from previous talk yesterday and from Cancer Australia, they have the most, some types of cancer, and they have cancers that have poorer diagnosis, later stage cancer, diagnosis, and they're less likely to receive adequate treatment. Now, the last two, I'd like you to focus on the last two, which the later stage of the disease at diagnosis and less likely to receive adequate treatment is what we, the Cancer Centre, can do something about, and this is what we're focusing on our work on. One of the key things that we wanted to do was to focus and try to make a difference in the last two discrepancy that I mentioned earlier. Now, looking at just from day one, we have collected these stats. We've collected stats, not just clinical information. We've collected psychosocial factors. We collected demographic data. We collected compliance. We collected cancer outcomes. We are going to publish by the end of, hopefully beginning end of this year or beginning of next year. And there was no research grant or anything like that. It's just one of the radiation therapists collecting the data. And we got quite good data, and it's quite a lot of the programs and policy we develop is because of the ongoing data that we collected. So I'd like to acknowledge Mary Pennyfather, who is the RT who collected that. The indigenous patients, the slide behind, back again, have got a high incidence of lung, which is this one, and they've got high incidence of head and neck cancers, gynecological, and also upper GI, whereas the non-indigenous have got higher incidence of prostate and skin cancers. So that is as expected. There's nothing different about that. Next slide. Now, as I mentioned earlier, when the cancer center was built, I used to go to Northern Territory and meet up with the Cancer Council because I used to coordinate patients coming from the Northern Territory. And when it was first published in 2010, the participation rate for radiation alone is 22%. And within, as soon as the cancer center opened, and we collected this data after 2 years, and it went up to 45 or 46%. It's just slightly lower than indigenous data. We're pretty proud of the participation rate. One of the key things of the participation rate is really the cancer center having a good reputation and being culturally appropriate. So news travels fast. And I've got to emphasize again in Northern Territory, people and the word of mouth is better than all the DVDs you can produce. No kidding. It's just from first-hand information. Next slide, please. So this is just one of the initiatives that we piggyback on the PEPA program. I'd like to acknowledge Anti-Palliative Care for helping me design this program. Mainly because PEPA works, so why don't we use oncology similar to PEPA? And we're not looking at a program that just train and send people home. We're looking at investing in the long-term future of the people in the Northern Territory. Next slide, please. So we came up with some aim. We had a group of people in the cancer center. We got the nurses, the ILOs, the doctors' seat is here. And we sat down and decided to come up with some aims that we can use a program to help Aboriginal cancer. So we wanted to target Aboriginal healthcare workers, mainly because, I'll go into that, mainly because Aboriginal healthcare workers are mainly the permanent staff in the community. And we got lots of nurses that transient, doctors transient, clinic managers transient. Aboriginal people are the people, healthcare workers are the people who stay there, who live there, who work with all the Aboriginal health issues. So I'm not going to go through that. It's just, to give them, we are actually trying to empower the Aboriginal health workers with the knowledge to actually assist with newly diagnosed cancers. As I mentioned earlier, if we can get them earlier. Just out of the topic. Last week we had the first T1 larynx. We had the first T1 larynx that came to the cancer center. We haven't seen a T1 cancer for 4 years. One of the data that we collected was compliance with treatment. When the first cancer center started in 2010, we had the compliance, we do a rough compliance rate, and it was about 85%. And now we're sitting on 95 or 96%. And one of the key things that work for us is to have an Aboriginal healthcare worker in the cancer center. So we actually have a full-time ILO. Practical things works, and we have to use practical things that works for us. And having the full-time ILO and also the ILO involved in cancer education is really the key. And we change our clinical practice to suit different Aboriginal communities, and I'll go into that as well. Click. To date, the grant to train this actually came from the Barrow project, which is the Radiation Oncology Commonwealth grant, and the aim is to do 24 CEPO graduates within 2 years, and we're on target. So we have done 22 now in May. We got a couple more to do, and this is where they come from. And it is not not as easy as what you see, because it's a lot of hard work trying to individually contact Aboriginal health workers to come forth for the training, publicity, marketing, and also to get the clinic managers to approve their attendance. Next slide, please. So we've got nice orange t-shirt. Is when the first Aboriginal healthcare worker was there, she wanted an orange t-shirt, so we decided to have everybody on it. So we have blue t-shirts, Smurfs, we are the Smurfs, the staff are the Smurfs, and the orange and blue. So they have a 1 week's training program with us. So next slide, please. So what we delivered was actually mainly clinical experience. The first couple of topics are probably a lot of basic principles. The first half day, a lot of basic principles until they fully engage and understand the principles of oncology. And then because it's so one-on-one, and it's so the most we ever had was 3 students at a time. Because it's so one-on-one, and they are having clinical experience, they take back more than just attending a forum or a course like that. All right, and I'll show you as we go along how we and impart the practical experience to the staff. Next slide, please. What the Aboriginal healthcare workers, this is a specially designed course booklet they use as a Bible. Inside there is all the basic principles, and also there's an assessment kit for them to assess patients who are newly diagnosed on what their needs are. And also there's another assessment kit for survivors of cancer. So it gives Aboriginal health workers a starting point on how to engage and start the conversation with cancer patients and cancer survivors as well. Next slide, please. One of the key things that work for us really well is because of our partnership with all the external and internal bodies of cancer. We've got breast cancer giving mentorship towards the prostate cancers. If they even visit where the accommodations are, the Nila Dilba has got our first Northern Territory Aboriginal Cancer Care Coordinator, and that came about through the only one that's funded by NTML, which is Medicare Local, and she has got 40 clients on the book at the moment from Darwin alone. She deals with Darwin alone. We need, if anything good, we need really badly is cancer care coordinators or navigators in Alice Springs, and we need them in Catherine, which is our 2 other key populated area. But they make a difference because patients will actually go through the journey in a much more supportive way, and also they get treatment at the appropriate level. So we've got Cancer Council, which provide all the resources. Cancer Council has been very instrumental in helping the CEPO graduate in Catherine and Royal Darwin Hospital. Next slide, please. So one of our aims is not just to educate them, but to engage with them in the long term. We want to form partners, so they know everybody in the cancer center by their first names. They can call us, email us, anything that they have regarding patients and cancer, they do it straight away. One of the key things I'll tell you later is about telehealth. So this is how we keep in touch with them. Every time there's a patient, Aboriginal is discharged in Catherine, we do a discharge summary, and then the radiation nurse will send it to the Aboriginal health workers. Emails, I get a lot of emails from a few of not all the graduates are very active, though, I have to admit, because some of them just go back and they've got other duties. And then we conduct a telehealth bi-monthly meeting. We've just sent out a couple, 2 newsletters so far. It's a new initiative. And there is an Aboriginal support group set up by one of the CEPO graduates in Catherine. And we actually, last Friday of the month, we rang up the support group. So we got the doctor, myself, and the radiation nurse, just talking to patients on the other side, or survivors on the other side. So it's just supporting the CEPO graduate in her initiative. All right, next slide, please. So that's the lady in Catherine, Velma. Next slide, please. She set up an information stand. Now, this is important, what works well. This one I just like to highlight, telehealth. Telehealth is one of the key medium that really works for us. And telehealth is going to be our future tool that we're going to use to engage fully with our CEPO graduates. What didn't work too well, we tried to set up internet forum. Recruitment with clinic managers was very difficult. And with Aboriginal healthcare workers have got more health literacy, which is much easier to do. Competing issues in the community, we've got renal, we've got cardiac, we've got all the other resources that is busy at the health centers. And cancer is just one of the list that's probably at the bottom of the list. Next slide, please. So we do community. The funny thing is we went to Milingimbi 2 years ago, and one of the ladies came and they remember us. Just coming to the cancer center and they remember who we are, and the embrace of the treatment was much better. We can do all kinds of DVDs and flip charts, but I was still saying the most important, the most effective one for us is direct communication. And one of these, the last initiative we're starting to do now is we bought a video camera, and the patient will do their own treatment diary, or they can do a comical screen. They can take home message directly to their families. The best communication is always direct. I have to say that again and again. So one of the ladies now is doing a video, and she's taking it back, and she just wants to pass the message on prevention and what to look out for and how not to be afraid of the treatment and so on and so forth. But these are the key initiatives. Some will work well, some doesn't work well. What will work well for us, we're going to focus on. So that's what we're going to do. We're doing it at the ground level. Next slide, please. This is how we consult patients out in the car park. Really, that's the environment that, they feel comfortable outside, so we go and meet them outside. So trying to catch patients to attend appointments is a challenge sometimes. So our consultants will go and sit in the car park and talk to them. That's very good. Just thought I took a sneaky picture of that. Next slide, thanks. Basically, I'd like to acknowledge the people in the Alan Walker Cancer Center and the people who are passionate about making a difference in Aboriginal cancer. Thank you.